Good afternoon, all. I welcome all of you on this Zoom web seminar on anesthesia in COVID-19 era. Anesthesia in this era is really a challenge because, as we all know, COVID-19 is a highly transmissible disease. So, in this era, our goal of anesthesia is not just limited to the patient's safety or providing just the safe anesthesia to the patient, but it also includes our own safety, safety of our healthcare workers, our whole OT staff, ICU staff, and we should try to do environment pollution or environment contamination as less as possible. So we anesthesiologists are at highest risk because if we see COVID-19 transmission, it is mainly happen by droplet transmission. So droplet is what when an infected person cough or sneeze, he produce droplets, and when any person come in the direct contact of these droplets or contact with the fomites, which includes these droplets, will become infected. If we see droplet particle size, that is 5 to 10 micron in diameter. So as they are heavy, they generally try to settle at the flow. So it will not remain much time in the air, but it try to settle at the flow. And as it is heavy, it will not spread more than 1 meter. So this is generally common mode of COVID-19 transmission. But other way of transmission is like aerosol generating procedures, which is also called airborne transmission. So what happens here? So because of these procedures, the droplets is called as droplet nuclei, and microbes are contained in that droplet nuclei. And if you see size of this nuclei is less than 5 micron, so it is lesser in diameter, they are lighter than the air, and they generally doesn't settle in the early phase of the generation. So they remain in the air, and because they remain in the air, they contaminate all the environment surrounding it. And as it is lighter, it will also travel more than 1 meter. So we anesthesiologists have frequently come across to the procedures which generates aerosols, and that's why it amplify our risk of getting infection higher. So what is actually aerosols? Nowadays we are keep listening aerosols, aerosol. What it is? So it is nothing but suspension of fine solid particles or liquid droplets in air or any other gas. So for example, fog or mist is aerosols. So how it generates? So any air movement over top of a liquid surface produces aerosol. So if we take our respiratory tract is lined by the mucous membrane, and which secretes the mucosa, which is the liquid, and over that liquid there is infected droplets are sitting there. So when we do like any maneuver which increases the air movement over this surface, like positive pressure, airway bag and mask ventilation, so that produces the breakage of the droplets and convert into the more finer droplets, and we call it aerosols. So as it is lighter inside, tends to spread more. So now aerosols will generate by two mechanisms. One is induced, so procedures which induce the aerosol production, and second is mechanical aerosol generation in respiratory tract. So intubation is an example of the induced aerosol. So when we try to intubate patient, and if patient is not deeply anesthetized, if he coughs or bucks at the time of doing our scoping, it will induce the aerosols. While bag and mask ventilation, droplets are already there in the over mucous membrane in the respiratory tract, and when we do the positive pressure ventilation, that time that will break these droplets and it will cause dispersion of these aerosols into the environment. So these are the two ways aerosols are produced in our anesthesia procedures. So bronchoscopy mechanism by induced coughs. So during bronchoscopy patient cough, it produced aerosols. Same way cardiopulmonary resuscitation CPR, when we are doing the deep chest compressions, it actually causes the higher expiratory flow because of pressure, in intrathoracic pressure, and that will also produce the aerosols. Non-invasive ventilation like BiPAP, CPAP or HFOV will cause possible mechanical dispersion of the aerosols and generate more aerosols in the surrounding environment. Tracheal intubation via cuff. So if we are doing intubation in a patient who is fully paralyzed, just doing the scopy will not increase the risk of much aerosols. But yeah, we are at risk because we are very near to the patient's airway, so we can get the transmission. But just intubation per se in deep plane of anesthesia will not produce much aerosols. Bag and mask in other way, it produce much more risk for aerosol production. Sputum induction, like for respiratory sample, it also induce the cough and produce the aerosols. Nebulizer treatment again cause mechanical dispersal because it is a high flow. Uh, that is one mechanism. Other important mechanism of open nebulizer, like what we give to the patient with the mask. In what happens if suppose patient coughs during the procedure of open nebulization, the whole his respiratory secretions, like which contains droplets, will go into the this nebulizer chamber, and now whole liquid has become infected. And think now we are aerosolizing the whole, nebulizing the whole that liquid, infected liquid into environment. So whole the surrounding environment become infected. So that's why open nebulizers we have to be very careful. Nebulizer which is connected via in the endotracheal tube and breathing circuit, that is we called in circuit nebulizer, which is distal, which is proximal to the HME filter, is not the aerosol generating procedure. Suctioning, definitely we are doing negative pressure inside the respiratory system, so it again produce the aerosols. One more important is the tracheostomy, which is a surgical tracheostomy or even our percutaneous dilatation tracheostomy. That procedure also produce the mechanical disruption of these droplets and cause dispersion of the aerosols. So we as an anesthesiologist, we many times frequently get exposed to all these procedures and we have amplified risk. Other transmission is by the fecal route. So as we all know, this COVID-19 is binds to the ACE2 receptors in the respiratory tract system. Now studies have suggested that these receptors, ACE2 receptors, are abundant in esophagus, stomach, duodenum and rectum. So there are some studies which have found that in 10% of patients initially presented with GI symptoms before they develop respiratory system symptoms. Another recent study from China, the study looking at 73 patients, they found that 24% remained positive in this too, even if they're negative respiratory samples, and they can transmit infection up to 12 days. So GI tract material fluids can also is a part of the infective material, and we are at risk whenever patient vomits or any open GI tract surgical procedures or endoscopic procedures, maybe upper GI or lower GI. So where all we frequently get exposed is emergency department or trauma center for airway management, at critical care, at pre-anesthesia checkup clinics or pain clinics, perioperative anesthesia care, and anesthesia at remote locations like cath lab procedures, endoscopy, ECT, and radiology, etc. So general principle is consider all patients COVID-19 positive. Whatever is the RT-PCR report positive or negative, consider all as positive, because incubation period for COVID-19 is 1 to 14 days. And initial period of the time, like for the generally for the first 1 to 5 days, there is very less viral load. And RT-PCR actually checks the how much is the virus load. So there can be chances that it will be negative in the early phase of the disease. So consider all the patient is having COVID-19 positive and take all the precautions, all the PPE in these patients. Elective and semi-emergency surgeries should be deferred only in emergency, and urgent procedures should be taken care. Frequent hand wash, we all know that. N95 mask is mandatory for anesthesiologists when they are giving anesthesia. N95 provides 95% protection of particles more than 3 micron. But remember, even aerosolization, whenever happens, that particles can be even less than 3 micron. So what suggestion is, we can put the N95 mask, and over that we can also put 3-ply surgical mask, so that will give the double protection. We can even use the N99 mask. Donning and doffing of PPE as per CDC guidelines, and before you actually do the procedure or get exposed, you do mock drill for donning and doffing of personal protective equipments. So this is the typical, on the left side, typical personal protective equipment required for the anesthesiologist. So it is N95 mask, and over that 3-ply surgical mask, white cover all. So all the body parts are covered. 2 pair of gloves, face shield, eye goggles, or even we can wear a helmet. Here in this figure, right side, we can see that the anesthesia is a mask and face shield, but this area, the ear and neck area is not covered, and there is chances aerosol can set there. So remember, cover all and no body part should be exposed. Pre-operative or PAC clinic or pain clinic, if patient is COVID-19 positive and patient is at isolation room, we should assess that patient in isolation room only. In PAC clinic, allow only one attendant with the patient and do temperature screening of both. Patient should wear 3-ply surgical mask and anesthesiologist should wear N95 mask with gown with face shield. History related to COVID-19 we should also evaluate, like cough or any fever and breathlessness, and any history of any contact or travel history. Blood test which may suggest that patient may have COVID is lymphopenia. So if we see the CBC profile, they all will have high leukocyte count, neutrophilia, but lymphocytes will be low, lymphopenia and low platelets. They have raised CRP, LDH, SGOT, SGPT, ferritin, D-dimer. Keep reasonable distance during airway assessment. Avoid checking for incentive spirometry as a part of bedside pulmonary test because it can also induce the cough and can produce aerosols. All reusable equipment like stethoscope, BP instruments should be frequently sanitized. At the end of the day, clean and disinfect PAC clinics and pain clinics by thoroughly wiping the surfaces of furniture, equipment and floor with 2 to 3% of hydrogen peroxide. Pre-operative orders, anxiolytics, because we all are in PPE and it will give stress to the patient seeing all doctors with this coverall suit. So anxiolytic is important. Antiemetics and prokinetics to prevent vomiting. Transport of COVID-19 patient. So if patient is not intubated, patient should wear 3-ply surgical mask, and this COVID-19 positive patient should be transported to COVID dedicated passageway and lift. Lift should be covered inside with the plastic disposable material. They should be changed once the patient has been transported. PPE must be worn by transporting doctor and staff. If patient is intubated, HME filter should be connected between the endotracheal tube and ambu bag. Avoid shifting patient on non-invasive ventilation or high flow nasal cannula because it produces aerosols and that will contaminate the whole environment from where patient passes by. Adequate sedation and muscle relaxation if patient is intubated to prevent bucking. Should be built directly into the OT without stay at OT hold. So pre-medication, any other thing should be done directly in the OT and they should not be kept in OT hold area. Operating room, ideal operating room should be negative pressure operating theater with minimum 12 air exchanges per hour. But in most of the hospitals in India, this is not possible, and even Western countries also. Because ideally, if we see operation theater should have positive pressure and laminar flow. So how we can convert this positive pressure OT to negative pressure? One is we can create is by reducing the amount of air volume entering the inlet duct while maintaining the air volume exiting through the other duct. So if we see design of operation theater, there are two things. One is air condition and second is this positive pressure flow. Generally, these both are come by only one vent. AC vent and positive pressure flow vent will be same. At the room of AHU, means air handling unit, the technician can decrease the flow of this inlet coming air. And if you maintain the same flow at the other duct, means exit duct, then there will be negative pressure. If you have any question, you can put down on the chat box and I will solve that at the end of this lecture. Alternatively, positive pressure and air condition can be switched off during intubation and extubation because these are the more aerosol generating procedures. Ideally, two adjacent OTs with one being utilized for the procedure and other as anteroom for the staff and doctors to wear and dispose of all PP is the ideal thing. In operating room, use maximum disposable items, plastic cover on equipment near head end and change the plastic after every case because as we have discussed, all our procedures can produce aerosols and aerosols will contaminate all our monitors and anesthesia machine. Use USG probes, machine TE probes, cable should be covered with disposable plastic as shown in the figures. Now choice of anesthesia. So regional anesthesia is preferred over general anesthesia because airway manipulation can be avoided. If patient should put 3-ply surgical mask and oxygen mask can be kept over this 3-ply surgical mask if required. Keep lower threshold for intubation during regional anesthesia, as we can get adequate time to apply PP if we need to do intubation. Avoid supraglottic airway as much as possible. Avoid mask ventilation because these both are associated with aerosols producing procedures. Minimize number of OT staff in OR during intubation and extubations. So what most of the guidelines suggest, only two persons should be there in the OT. One is anesthesiologist and one is the anesthesia technician. Rest all surgeons, staff should stay outside the OT at the event of intubation and extubation. And at that time, we should generally, ideally create a negative pressure or keep the positive pressure off and make the neutral pressure. Other can enter OT after 15 minutes of the event. Preferably, most experienced anesthesiologists should do the intubation because second attempt of intubation is associated with more aerosolization. Video laryngoscope is preferred because we can stay away from the patient and do the intubation. Consider rapid sequence induction. So all the guidelines, European, American, Indian, all the guidelines suggest that we must use rapid sequence induction so we can avoid mask ventilation. So how we can do that? 5 minutes of pre-oxygenation, rapidly acting muscle relaxant like succinylcholine or high dose rocuronium. If manual ventilation is required, do with the less tidal volumes. And before we do the scoping, we must check that patient is fully paralyzed, because if patient is half paralyzed and if we do scoping, he will do buck or he will cough and that will produce more aerosols. So confirm that patient is adequately paralyzed, give enough time for succinylcholine or high dose of rocuronium to work. Generally it takes 30 seconds. After intubation, inflate the endotracheal tube cuff with adequate seal before we start ventilation. So we can protect aerosols from the respiratory tract to coming into the environment. Double glow technique during intubation. So after intubation, remove one glow and remove that one glow over the this laryngoscopy plate and send this laryngoscopy plate for decontamination. What if it is difficult airway? If it is difficult airway, low tidal volume ventilation between attempts. If it is anticipated difficult airway, one more anesthesiologist should be prepared with PP inside the operation theater. After failed second laryngoscopy attempt, put the supraglottic airway, preferably intubable, like intubating LMA. Then we should do intubations through the supraglottic airway, preferably by disposable fiber optic scope. And early cricothyrotomy is recommended in can't intubate and can't ventilate condition. Awake fiber optic intubation is ideally, it should be avoided. But if it is really mandatory, then every attempt should be done to minimize coughing and decrease patient anxiety during the procedure. We should give adequate sedation so it will not generate cough for the patient. Avoid lignocaine spray and nebulization because that is also aerosol generating procedures, but we can do topical lignocaine, like lignocaine viscous gargles can be allowed. Avoid transtracheal block because transtracheal block also cause the cough. Superior laryngeal nerve block can be given. Use flexible disposable fiber optic scope whenever possible. If there is some difficulty, we can intubate via supraglottic airway device. And early cricothyrotomy in can't intubate, can't ventilate condition. HME filter. Nowadays, the most important part of our anesthesia circuit is HME filter because it can prevent, it is protective, 99.997% is protective against coronavirus. And if we put two HME filter in a series, it will prevent 99.99% against the coronavirus. So first HME filter should be connected between the endotracheal tube and Y part of the breathing system, and second should be connected between the expiratory limb of the circuit and machine. And gas sampling line for EtCO2 or gas sampling should be connected distal to the HME filter, so our gas module will also not become contaminated. Avoid circuit disconnection as much as possible, and if it is required, do at the end of expiration so it produces less aerosols. At the time of disconnection, we can even clamp the endotracheal tube. Maintain the anesthesia with IV anesthetic agent so we can avoid the vaporizer inside the operation theater because we don't have disposable vaporizers. Open suctioning is aerosol producing procedure, so we should do closed suctioning. If open suctioning is required, we should take all the PPE precautions. Lung protective ventilatory strategies like with optimal PEEP lead should be less than 35 mm of Hg to achieve SpO2 more than 90% and admissible hypercapnia. Now this COVID-19 positive patient can be of two types, high lung compliant or low lung compliant. So high lung compliant we should give less PEEP, and low lung compliant we should give more PEEP. Generally keep the lungs dry, so don't overload the patient with the fluid. Restrictive volume strategy is the ideal. Extubation is actually more aerosol generating procedure because patient generally coughs at the time of extubation. So ideally it should be there in negative pressure room. But if you don't have such room, it is better to extubate on table in operation theatre rather than we shift the patient to ICU and do the extubation. Antiemetic should be given before extubation and consider to extubate in the deep plane of anesthesia so we can prevent cough. Post surgery, once surgery is over, doffing of PP as per the CDC protocol. There should be two staff. We should transport this patient from operation theatre to ICU or the recovery room. Out of two staff, one should wear sterile gown, glove and N95 mask, and the other should not wear the sterile gown. And the person who is sterile, he should manage the patient environment like ambooing or something is required. And other staff who is unsterile should touch the other environment like lift or door, like that. So after patient is out of OT, close the OT door for 30 minutes with air condition on and followed by deep cleaning. Whatever plastic we have kept on the equipment should be removed before deep cleaning, and that all the equipment should be deeply cleaned. Discard breathing circuit, mask, tracheal tube, HME filters, gas sampling light and soda lime after every patient. Post-operative concerns, avoid out-of-circuit nebulization. So when nebulization with mask should be avoided. Avoid non-invasive BiPAP and CPAP as much as possible. Avoid high-flow oxygen therapy. Avoid open suctioning, always do the closed suctioning. For any aerosol generating procedures, ICU staff or doctor should wear N95 mask, full cover gown, face shield or hood, goggles and shoe cover. Last slide, personal care, very, very important. Carry minimal required personal things at hospital. Avoid wearing watch, ring. Spectacles should be clean with 70% or more alcohol. Pen, which is very important, we generally forget to sterilize this, so it should be wiped with the 70% or 80% alcohol and keep it in the plastic bag and store it our locker only. Don't take the pen to the home. Sterilization of mobile before leaving hospital with 70 to 80% of isopropyl alcohol, that is safe for the mobile screen. And bath at home before greeting the family members. These are the references. Most of what the information I gathered is from the recently 2 articles from the Indian Journal of Anesthesia, which is the first 2 references, and few from the recommendations by American Society of Anesthesia and European Society of Anesthesia. Okay, fine. So we'll close this session. Thank you very much, everybody, for participating. Thank you very much.